Good morning, everyone. Before we begin, I have some housekeeping that I would like for you to hear. Welcome to the 2021 Oxford House World Convention. As a reminder, masks must be worn indoors properly. Lanyards and name badges are required to enter sessions. Please silence your cell phones during each session. Be respectful of the colored bracelets and people's contact preferences. Keep your QR code on your name badge clear so that we may scan you into each session. The only smoking and vaping area we have is outside, between the ballroom and the parking lot. Don't smoke near the doors, and please dispose of your butts properly. Don't forget to rate the sessions on the convention app. The AA meetings have been moved to National Harbor 3, and the NA meetings have been moved to National Harbor 10. And with that said, I'm Jeremy, and I'm a person in long-term recovery. Hi, guys. My sobriety date is April 5th of 2013, and for that, I'm truly grateful. So today's session is dealing with health issues, more so dealing with health challenges. And the description reads, about half of the residents of Oxford House have a physical or mental health disorder that requires medication to control. This panel will discuss medicines that fit within an Oxford House environment and those that undermine the alcohol and drug-free foundation of Oxford House living. Note, medically assisted treatment will be covered in a panel in the next set of breakout panels. Some medicines are not permitted because they may be illicit or cause mood-changing behavior and be addictive. On the other hand, some medicines are correctly prescribed and may be necessary for controlling serious mental illnesses or making a transition from addictive use to comfortable sobriety. The panel will consider how such situations are handled and the steps that are taken by Oxford Houses to guard against the misuse of legitimate medication. The panel will also discuss how to use lockboxes to avoid easy access to medication. Following opening remarks by the panelists and the moderated discussion, the members of the panel will respond to audience questions. The panel consists of medical professionals, Oxford House alumni experienced in dealing with health issues in Oxford Houses, and Dr. Hoffman, who is a longtime member of Oxford House Inc.'s Board of Directors. I love this panel because it allows for us to talk about the real things that are going on in Oxford House, because we all come in, most of us come in dual diagnosis. When I was in treatment, I was diagnosed with paranoid schizophrenia. Meth took me all the way out. And hearing voices, seeing things, there was medicine that I needed to control that. Also too, in my first few months of recovery, I felt it very imperative to start to love me unconditionally. And I was being deceptive. I was lying to myself about what was actually going on with me medically. I'm HIV positive. I've been undetectable for the last 8 years, the entire length of my sobriety, but before that, thank you. But before that, I was denying the fact that I was ill. I was not willing to look at that aspect of myself because it was a consequence of some very poor choices that I made, right? But when I interviewed at my house, I told them, and it was like a weight was released from my shoulders. And they welcomed me with open arms, and they loved me and held me accountable to going to my doctor's appointments and taking my medications on time. And they celebrated me when I got my first undetectable status, and every 6 months after that. And it just made me feel like finally I was accepted and I had family that really cared about me as a person, as a whole person, right? And so that's why I'm happy that we have this panel so that we can discuss these medications and what it's going to take for us to actually heal mind, body, and spirit, all right? So the first person that we have up is Elizabeth Lewis. In 2010, was accepted into Oxford House Shirley Ann, located in Tulsa, Oklahoma. A year later, she was hired and moved to OKC to contract with a program which helped pregnant women who are IV users getting sober out of prison move into houses to learn how to live again and become mothers that God intended them to be. She then moved to pioneer the state of Mississippi when Oxford House received the contract. She opened the first dozen houses and dealt with some hardships when then awarded with her first 2015 Founders Award at the annual Oxford House World Convention. After that, she was able to work in her home state of Texas, where she began the senior outreach. 2 years ago, the state of Florida was granted a contract as well, and Elizabeth was asked to assist in establishing houses in Florida, where she is currently living and working as the senior state coordinator. Please welcome Elizabeth Lewis.
Hey, y'all. Hi, I'm Elizabeth Lewis. I'm a woman in long-term recovery, and what that means for me is I haven't found it necessary to drink or use since January 24th of 2010, and I cannot believe that. I know, right? It's pretty impressive. So years ago, I was in Tulsa, and Jackson was my boss, and I went to a world convention as a resident the first time. And then the next year I was hired, and like they tell you what panel you're going to be on about a week, maybe a week before you're up here, which I don't even speak. At that time I didn't speak in meetings because I was terrified, right? So now I'm speaking at World. And so then he was like, your topic is dealing with health issues. And so like I'm active, I'm fit. So I was like, oh good, I can teach like a boot camp class or something. But he said, no, it's HIV and hepatitis C. And I'm like, oh, and I was like a year out of the interferon. I'll get to that in a minute, hep C. But, and I was like embarrassed. I was like, oh my God, because I was in fear. And then I had my ego and pride. I was like, but I talked to my sponsor and I prayed about it. And now I'm just so grateful to be able to be up here and share my horrible experience with y'all, because hopefully I'm going to be able to help or guide, or at least let you know that you've got another sister in recovery to guide you along the way. And that's what this thing is all about. So, and in fact, although I do get nervous, I was upset when I was not on the panel for a couple years. So that's interesting how things change, right? So, all right, in 2010, like I said, I moved into the Shirley Ann house, and I knew I was HIV. I knew I had Hep C, but I didn't. When I found out, I was deep in my drug use, IV drug user, and I was like, I got 20 years before that gets me. I didn't think I'd live out of my 20s, so like I'm good, right? And then so at year, I think 5, I moved to Mississippi, and I went. By this time I'm working, I have insurance, and I want to go to the doctor. And of all doctors, I went to the gyno, and she was a beautiful Latino woman, and she was like, oh, you got to take care of this. And I don't know why, but I listened to her, and I was terrified, but she gave me a GI doctor, and I went to that GI doctor. I talked to my sponsor about it, and she was like, this is amends to yourself. Like, it is good. You have to love yourself. Because I had done my amends for the people I was willing to or financially able, but I forgot about me. And so she's like, yeah, mind, body, and soul, you gotta do this. You gotta take care of it. And I was scared. I went to my GI doctor, and they sat me down, and they said, you're going to need a support group. Like, this is bad. And this is old school interferon, which I don't know if y'all know. It's like a mild form of chemo, if you will. It's nothing compared to the cancer patients, so please don't mishear me, but it sucks. And so anyway, she's like, you're going to need a support group. And I knew I was living at Oxford House Rodenberg in Biloxi, Mississippi. Anybody from Mississippi in here? Yeah. Okay, well, I was kind of excited. But, and I had those women, and then I had the most amazing, God is so good, because I had the most amazing support group I do NA, or did NA at that time. And my sponsor, there was 7 of us that we all had 5 plus years at that time. I was 5 years sober. And they supported me. One of my sponsee sisters had gone through it. And so because the doctor told me you're going to have to inject yourself, and I love needles, right? So I was like, I don't want needles in the house, and it's a different kind of needle, but the fact is I'm still poking myself. In the interview questions where they ask you, what are your triggers? Mine were the guys with the veins, the workout guys, Tylenol bottles shaking and needles, right? And so I was like, ooh, I don't want to have that in the house, but I had to sit down with those women and say, look, these stuff's going to be delivered to me in a cooler, and we have to keep them in the fridge, and so that triggers them. I will have a sharps container trigger, all of this stuff. So I have to be open and honest and tell the ladies in my house, like, this is what's happening. And they were totally okay with it. They were like, we're fine, you're fine, we'll take care of you. And, it's emotional. So I was on interferon and then ribavirin and what's that horse with wings, whatever they call? It was like that. It reminds me of that. It was another medicine, but you have to take it. I think I was like taking 12 pills a day and some injections in my stomach. But I got really, really sick. They told me, you're probably, and of course I'm vain. So I was like, I'm going to lose my hair. I was just a little, but I did do that. And I was so sick. I couldn't, I had blood transfusions. I had lab work every twice a week, and my treatment lasted 7 months. It was horrible. But the girls, when I was too weak, they would change my sheets. They would bring me ginger tea for my nausea. They would bathe me. They would, my NA ladies in the room. I don't know why this is so long ago, but it just means so much to that. I had all this love wrapped around me, and they would bring meetings that I would sit in my bed and we would read, and I needed that because you have, I guess the interferon, and Dr. Hoffman may know better, but I guess you get suicidal thoughts and real depressed. And so, and I was just terrified to relapse. I didn't want to lose my home. I didn't want to lose those women. I didn't want to be cut off from the sunlight of the spirit, And so, but, I was taught in the program and in the house, these are things you got to talk about. It's highly uncomfortable. But we got to do it. We have to talk about it. It's good to ask questions, when you're in an interview or, when you're interviewing somebody. And one of the questions is, what medications are you on? We're not legally allowed to ask what's that for, but we all have phones, we can Google. And another interview question is, are there any, gosh, I haven't seen an interview thing in a long time. Are there any health issues that we need to be made aware of? I think that's one of the questions, right, guys? Y'all should know. But anyways, we're not obligated. We don't have to tell you. So I didn't, and because I was embarrassed. And so, but after I opened up and I did the statistics, like 1 in every 3 IV drug users had hepatitis C. And other people were like, welcome to the club. Like I was around, family. You know how we tell horrible stories in AA and we laugh because we can relate? That's what I felt. I wasn't shunned. I wasn't like, looked at, I was welcomed. And it's so cool when we put our guard down that we can get that positive feedback, and that's what this thing is all about. So anyways, I go through that. Oh, my phlebotomist, right? Because I'm a hard poke. And she and I became friends because she was the only one that could draw my blood. And I was invited to her wedding. Like, we became that close. It was really neat, all these little things. And, and now I was, and money. It was so expensive. It was like 30 grand. But we're hustlers. I found money because I am frugal. I used to say cheap, but I'm not supposed to say cheap, so I say frugal. And, but I found there's so many at this time, now it's free, but there are so many grants that I found. And even with insurance, it was like astronomical, the number of cost of the medicine. But today, the good thing, and during my treatment, the doctor said, Elizabeth, you're going to be really upset. I'm like, oh my God, it's back. Because I was undetectable too after I think 2 months. It was crazy how quickly, I don't know what the word is, the blood set, whatever it was undetectable, but you still had to go through the treatment. The viral load, yes. So that was amazing. But, what was I saying? So during the treatment, she's like, you're going to be upset. And she said that the new drug has been FDA approved, which is that 12 weeks. I think you'll take it for 8 or 12 weeks, 1 pill a day. I think your mild symptoms, like it's such a blessing. And I was just so grateful because I didn't want anybody to go through that, and it's a blessing. So I read some statistics last night, and with this new antiviral medicine, I don't know the name of it, but it says it can cure 95% of people with hepatitis C. And according to the CDC in 2018, there are the number was 50,300 per year that are infected, and then 58 million worldwide people are living right now with hepatitis C. So it's out there. So what I recommend is taking universal precautions. Do y'all know what that is? You treat everybody as if they're infected. I was a dental assistant, that's how I know. But you treat everybody as if they're infected, So, and right now, especially, we wear masks, we're gonna treat everybody as if they're infected. Same thing, like don't you leave your razor in the bathroom, don't share clippers and, toothbrush and things like that. You wanna, just be mindful. And I will say this, when I was Shirley Ann, my first Oxford house in 2010, well, it wasn't my first. My first was 2006, but I got kicked out for shooting coke in the bathroom, but that's another story. So come to the next panel, I'll tell you all about that. But it's true. But in 2010, Shirley Ann, we did a phone interview, which hopefully all your houses do phone interviews, but we did one and we put her on mute and we accepted her. We did the welcome home bit. And then she was like, great, I get out of treatment tomorrow. I'm just gonna go to the health department to get my results for Hep C. And we're like, oh, hang on, the girls were. And at this time, they don't know I have Hep C. And they're like, if she has Hep C, we can't accept her. I was like, fuck you all. Sorry, camera guy. But I was mad. Sorry, Paul. But I was so like, that's not, but I learned after calling my sponsor, it's my duty, I guess, to educate these naive people. And boy, I did. I was on a couple behavioral contracts after, but not because of that. But if you don't work out your resentments, it then bleeds into other things, and then you get on behavioral contracts. But so after that, we didn't accept her. So that's a good thing. But it's all about communication, open communication, be vulnerable, talk about it. And if it's HIV, if it's whatever else, like everybody deserves an opportunity to be sober, right? They deserve an opportunity to be in a safe place that we can actually have a chance. Because that's what's beautiful about Oxford House is that 24-hour peer support. We are not alone. So whether it's amoxicillin or birth control or methadone, like we all need to talk about it in the house. It's got to be documented. It's got to be locked up, all of that. We got to take these precautions because most of us are on meds, So, and then two, if I'm on a medication, like say I go to the dentist and they give me an antibiotic, not a pain pill, just an antibiotic, it is my duty to still go to that house meeting and say, hey, I just got a new medication. And so all of that needs to be talked about. It's very, very important. And then two, where's my time? Oh, okay. So into the newcomer packets, it should have your medical emergency information. That really is important to do because anything, we need to know like who to call and what to do. And they should be like very organized so we can get to them quickly because things do happen. So we just want to be cautious and all of that. So I think that's it. After the 7 months, I think it's kind of like cancer. You go get labs for 2 months, for twice a year for 2 years or 3 years. And then the third and fourth year, you get labs once a year to make sure you're good. And then on the 5th year, you're considered cured. So I don't know why 5 is that magic number. So I'm cured. It's pretty good. So, yep. And I think that's really all I have. I'm just, again, so grateful. And if y'all have questions, I'm sure we'll do that after. But I'll stick around too. And if y'all, I can guide you and we could find treatment in your area and all of that stuff. But love yourself, get tested, love your liver, get treatment.
Thank you, Elizabeth. So when I spoke earlier about me telling my house about my HIV status, I just want to qualify by saying self-disclosures are not required in Oxford House, right? So you're not required to tell the house anything that you have going on with you medically, okay? For me, it was very important because I needed to be held accountable. And I was disillusioned to think that I wasn't lying to people by not telling them, right? And so I wasn't actively lying, but I also wasn't being truthful. And so I needed to do that for myself in efforts to be held accountable again and have my house support me. So I just wanted to clarify that before we continued. Next, we have Jordan Link. He's a man in long-term recovery who has been clean since April 1st of 2016. He was born and raised and has been homeless and now is recovering and helping folks just like him in Western North Carolina. Jordan has been an outreach coordinator since November 15th, 2018, and he truly believes he couldn't or wouldn't be here today if it wasn't for each and every one of you. I welcome Jordan Link.
Good morning. My name is Jordan Link. I'm a man in long-term recovery, and what that means for me is I've not had a drink or a drug since April 1st, 2016. I can remember early on in my Oxford House experience, being like, oh man, I really want to speak at one of those world conventions, and here I am. Boy, do I regret that. No, I'm just kidding. So I'm going to speak a little bit today about prescription medications. I have my own experience taking prescription medication in recovery, and I also have experience dealing with others that have taken prescription or are currently taking prescription medication in Oxford houses and in recovery. So first I want to talk a little bit about, obviously my experience with coming into recovery and the opinion that I had about prescription medication. So, me being a recovering addict, I'm a member of Narcotics Anonymous through and through. I believe in the 12 steps and 12 traditions of NA. That is the fellowship that I call home. And I had a lot of interactions early on with. First of all, I was told to get with the winners. And so that's what I did. And I got with a lot of folks that had, 10, 20, 30, 40 years clean. And, their views on prescription medications weren't, I wouldn't say they were skewed, but they didn't necessarily have the experience that I've, found in recovery for myself, as well as seen the experiences of others. So I would say early on that my experience was very skewed regarding, prescription medication and the use of it. So, fast forward a little bit, I'm working for Oxford House now, and it's 2019. I'm headed to my first staff training, and, that morning, the morning on the way there, I drank an energy drink, and this energy drink just really, I'm not going to blame it on that. I will say, let me back up for just a second. I will say that we do a lot of damage to our bodies, and I did a lot of damage to my bodies, and there were things that I neglected to take a look at in active addiction. And, once I got into recovery, it was important that, I utilize it. Like, I've got health insurance, that's great, utilize it. So that's what I did, and I had some problems that happened, and I'm not going to go into great detail about about the procedures that I've had in recovery. I don't feel like that's important. I feel like it's important that I do say that I'll give you one small detail, is that I had to walk around for months at a time with a bag strapped to my leg. So put the pieces together. Again, not going to get into great detail. Y'all can do that yourself. So the first time I had to have this procedure done, I was given narcotic pain medication. Okay. And, I was scared. There was a lot of fear behind that because, I didn't necessarily have a drug of choice. I can remember in treatment them asking me what my DOC was, and I was like, what's DOC? Department of Corrections, I didn't know. I didn't know what DOC meant. This is that had been my first time in treatment, and that was one of my DOCs. So there was a lot of fear behind taking prescription pain medication, and I got it. I got it from the doctor. I fully disclosed with the doctor that I was a recovering addict, and that I worked in recovery, and that I had, at this point in time, a little over, I think I was coming up on 3 years clean at that time. And still, even then, there was, like I said, a lot of fear behind that. So I got the medication, and I'm the type of guy that, if it says take 1 every 4 hour, back then I took 4 every hour, right? That was just the kind of addict that I was. And so I had somebody to hold me accountable. My fiance is in recovery as well, and so she was helping administer that medication on time and making sure I was taking it as prescribed, which of course at this point in time I had no intentions of not taking it as prescribed, because my recovery, my desire to stay clean at this point was way greater than my desire to use. So I had that accountability there. At this point in time, I was not living in an Oxford house, but it was important to me. I had learned in Oxford house how important accountability was, and it was important that I had that, whether I was in a house or not. So I'd like to say I made a full recovery from that procedure, and I did pretty well. And fast forward, 6-7 months, I had not made a full recovery from that procedure, so I had to go back and have it done again. So again, walking around, I remember having the state convention back in 2019, and I was wearing this suit, and I was walking around and still had that bag on, So I had to have it done again, and I want to back up for just a second. I did not finish the medication. At this point in time, it was playing tricks on my mind, and so I didn't finish the medication. I disposed of it properly. And the second time I had to have this done, I had realized how awesome Tylenol and ibuprofen was, so that's what I decided to use instead. And so I've made a full recovery from that since then, healthy, doing well, and I'm grateful for that, very grateful for that. And I do want to say that when this all happened, I had people surround me. I can remember coworkers, and I can remember residents in Oxford House bringing cards, and one of them brought me a teddy bear. A grown man brought me a teddy bear and pizza to my house, because I was not able to get out and drive myself. That's what happens in here. We get close, we become a family, and through Oxford House, I've developed those relationships, and those people held me up at my lowest times. And for that, I say thank y'all. Told myself I wasn't going to drink any water, and there we go. So now I want to talk a little bit about, my experience in dealing with folks in Oxford House that are on prescription medications, and obviously the procedures that we have surrounding that. Back up to early on in my Oxford House experience at the time, this thing called MAT and folks taking prescription medication, narcotic medication, anything that I'm mainly talking about, anything that has a high risk for abuse. But again, if anybody like me, I'll find a way to abuse anything. But I'm up here mainly talking about narcotic medication. So I had that negative outlook on that. That's what some of the folks in NA had taught me, is that we don't abstinence from all drugs, right? That's what I had learned. And so fast forward, I start going to state conventions, world conventions. I start asking questions. I start getting with the winners up in here, right? And I start learning some things about folks that take medication. And I will say real quick, I'm looking on time. Okay. I will say that I have family members close to me that are in recovery and that are on medications. And so obviously that helped change my opinion, but y'all helped change my opinion too. The experience of others that are recovering, and everybody's path looks a little bit different, right? But it's important to realize that we're all going to get our lives back together. We all come from a different place, but we have so much in common, and it's important to realize that some folks take certain medications and that's their path of recovery, and that's okay with me today. Early on it was not. I had, if I'm being honest, I had very negative opinions. And, today I can say that what works for you may not work for me, and what works for me may not work for you. So anyway, in regards to like narcotic medication, so we have folks in our area, multiple folks that are on narcotic medications, That being said, that is something that needs to be disclosed. And again, like was already shared, the reasoning why is really irrelevant. If somebody's on a medication, they do have to disclose that. And if they come in, they have to have the note. They have to have a letter from the physician, right? They have to have a letter from the physician stating that this person has disclosed to the physician that they're a recovering addict or alcoholic, and that in their opinion, there's no non-narcotic alternative, right? That being said, it's important that anything that does have a high risk for abuse is kept locked, not in the house's lockbox, right? Yeah. Right? That person has to have their own lockbox. And then, it's important that I don't necessarily know, this may be done a little different everywhere, but the way we do it in North Carolina is that medication is counted twice a week, The way we do it once randomly, and then one time at the house meeting. And we never touch, anytime I've had to do this, I've never touched that person's medication. It's not my job to lay my hands on this person's medication. And obviously, if that medication is triggering to somebody else, if that's their DOC, then, maybe we need to find somebody else in the house that's comfortable in watching that. So anyway, it's something I've watched over the years, and I'm by no means an old timer. I still consider myself a newcomer because the more I think I know, I realize I know a lot less. And so I've watched over the years folks get their kids back in their lives, and get their families back, and make those amends, do all those things, whether they're on medication or not. And I don't really know what more I have to say, but I do know I'm very grateful to be here, and obviously if there's any questions about prescription medications, I'll be happy to answer them. And I'll leave you with this: I appreciate each and every one of you, and it's people like you that make the world spin the right way. Thank you.
Thank you so much, Jordan. So I like to consider myself a health advocate. The reason why is because I needed to find out what was going on with me, and in doing so, I was able to find out what was going on with others. I also decided to take on nursing school, so that was fun. And so it truly helped me to really help my peers and understand what we were going through. HIV is my specialty, just because that's where I am in life. And so when I spoke with my house about my HIV status, it was very important for me to dispel any rumors or any misinformation that we may have about how it is contracted. And so I felt it necessary to share it with you guys so you could take it back home, right? So there's 3 main ways that HIV can be contracted from another person. Does anybody know? Yes, okay, give me one. Yes, intravenously, so IV drug use with someone that is currently infected and does not have an undetectable status. Anyone else? Yes. Yes, both of those. Through blood transfusions, which is really, really unlikely these days. They do a lot of testing on blood before they actually do the transfusions. Back in the late 80s, early 90s, those tests weren't done as frequently, and there was a lot of passing or more than enough passing of HIV through blood transfusions. And the most common way is unprotected sexual practices with someone that is currently not at an undetectable status. Now, a mother can pass along to her child. That also, too, is very highly unlikely because if the person is taking care of themselves, going to their doctor's appointment, they will have already disclosed this to their doctor, and the doctor will be assisting them medically in efforts to ensure that it's not passed along to the child. So, with that said, that did not include spoons. That did not include drinking behind someone. That did not include eating behind someone, sitting on the same toilet. That did not include taking a shower after someone, using their bath towel, none of those things, right? And these kissing, none of those things. And you really wanna go ahead and talk to individuals that do have this misinformation because some people really do believe that. They really do believe that if they kiss someone else, they could potentially contract HIV. And it's just because they're misinformed, right? And so our due diligence and my duty is to ensure that everybody has the correct information. When Liz was talking about hepatitis C, I also studied a lot on that as well. That is highly transmissible, right? And so we do want to make sure that we're not sharing our personal toiletries. That's very important. Your razors, your toothbrushes, right? You want to keep all of that in your personal caddy. Take that caddy back to your room when you're done, Ask before you use something. If you need a razor, I got you. I got plethora, okay? Look at my face, smooth. You need an extra toothbrush? I got you, fam, Also, too, partner with your local LGEs, that's what we call them in Louisiana, your large governing entities that are giving grants and funding by the state. They provide condoms. Look, in my house, I had a bowl full of condoms. And they would just sit on the table. They're just on the coffee table. So if you needed a condom, just pop that out and go enjoy yourself. All right, next. I know, we're gonna end on the condom, right? Yeah. All right, next we have Miss Sarah Graham. Sarah is an outreach worker in Southern Arizona and is the editor of the Arizona network of Oxford House newsletter, AZ Does It. She is in recovery from both addiction and mental illness. Sarah is a certified peer support specialist in Arizona and is currently working towards her national certification. Please welcome Miss Sarah Graham.
Good morning, everybody. My name is Sarah. When I go to an NA meeting, I'm an addict. When I go to an AA meeting, I'm an alcoholic. And today, I'm a woman in long-term recovery. And what that means for me is that the first thing I think about when I wake up in the morning, the first things I think about are not how can I make myself feel better. The first things I think about are I need to say a prayer. I need to ask for guidance to be as helpful as I can today. And feeling better is not the point of my life anymore. So I'm very excited to be here. My first conference was in 2019, 2 years ago. I'd only been in Oxford House for a few months, and I remember how terrified I was asking a question at that microphone. I had no idea that I would be here, especially for such a self-disclosing panel. So everybody here has covered quite a few things. I'm gonna do a little bit about medication accountability. But one thing I really want to, so I don't just struggle with the spiritual malady of addiction. I also struggle with mental illness, emotional illness. I have had very, very serious depression for most of my life. And what I didn't say in the beginning is one of the first things that I would think about for a very long time was when I would wake up is when can I go to sleep again? It was very difficult for me to make it through an entire day and not have to plan. Some people plan lunches or meetings or go to the gym. I went to sleep. So I was an intravenous drug user. I was definitely self-medicating. I was first addicted to methamphetamine, which the first time I used it intravenously, I had this feeling like, oh, this is what it feels like to be awake. And it was incredible for me, and I couldn't stop. And then during a period of my life where I was living in a house where that's not a medication, where that drug was being sold along with heroin, I got very, very depressed, wanted to kill myself, decided, I had seen plenty of people overdose, brought plenty of people back, and I knew that heroin was a good way to do that. But I didn't do enough of it that day. And when I did come out of it and I was still high, I thought, oh, okay, I can handle this. I can handle life if I feel like this. I had been to college before I started using hard drugs. I was 35 and before I touched a hard drug in my life. I had been to graduate school and gotten a master's degree in English. And shortly after I started using and moved in with a drug dealer, I was living in a homeless camp for about a year and a half. And after that, when I broke up with the drug dealer, broke up with the guy who lived out in the woods, I found a guy who lived under a bridge. And so that's where I lived for the final part of my sobriety. So for me, when I got clean, I got arrested. I didn't want to be clean. I didn't want to be alive, but I didn't have any, I didn't care enough to kill myself. So for me, for one thing, being on medication-assisted treatment when I came into recovery was really important. I knew I didn't want to go to jail, and that was about all I knew. And I came off of heroin with Suboxone and treatment, and there were a lot of sober livings in the area where I lived that would not allow people to be on medication at all. So when I found Oxford House, and I was on Suboxone for quite a while, and that was very helpful to me. So what I want to talk about medication accountability a little bit. I want to talk about mental health issues as well, because another thing I've been treated for is Hep C, and I was lucky enough to use the medication that was a pill a week, 12 weeks, and it was almost like I wasn't on anything. But I was so ashamed when I found out that I was Hep C positive. I felt like I was dirty. I felt like there was something wrong with me, and I definitely didn't want anybody to know. But that treatment that I've been through in Oxford House has been the least embarrassing. When I finally told my house, they said, oh yeah, we've been through that too. It was almost like just something that everybody that I lived with went through, and it was not a big deal, and that is such a blessing. However, a lot of people are still very anti-MAT. And when I came to the World Convention 2 years ago, and I would see presentations by people who were experts in medication-assisted treatment, and I would hear, well, it's okay for you to be on it. But I didn't know anybody that I respected that was on it. And so I'm here to tell you guys I've worked for Oxford House for for a year and a half. I've been clean for 2.5 years. I have a beautiful life today. I have a I have better communication skills and better relationships than I've ever had. And I'm happy. I'm happy. So I've been on Suboxone. I've been on other controlled medications, which I mentioned what my issues were. I'll also let you guys draw your own conclusions about that. So I want to talk a little bit about medication accountability in houses. Of course, we don't have to disclose what our issues are, as people have said, our medical issues, but we do have to disclose what our medications are. And for me, it was really, really important to be honest, because self-medicating is what I did. Okay. Thank you. All right. And I had a lot of questions about this. I didn't know, can you be on medications in Oxford House? How do we deal with it? So discuss it with your house. And this goes for mental and any kind of disorders that people have. If they're on medication, we need to discuss the medications with the house. This doctor's note, which I'm going to show you all in a minute, there's, I don't know if it's in the Google Drive that you guys have access to, but if you ask an outreach worker, they can show it to you. It was written by Oxford House, and it gives the basic guidelines, and the rest of it is mostly up to your house. How does your house feel about it? I'm going to go over medication counting. I'm going to talk a little bit about lock boxes. And the biggest thing we need to do in any situation in Oxford House is focus on behaviors. A diagnosis is not what's important. The medication somebody is on is not what's important, because I'm not sure if you guys have ever experienced somebody who has mania. Sometimes it looks a lot like they're on meth. People with major depression or sleep disorders or narcolepsy can look a lot like someone's on heroin or fentanyl. So what we need to do is we need to look at what they're doing and if they are recovering and if they are a good member of our house. Okay, thank you. All right, so discuss your medications with the house. If I have a history of self-medicating, I need to be honest about it. How many of you have ever seen an application or done an interview and heard the name of a medication and thought, oh, that's not going to work? Yeah. If you saw my application with my medications, you would definitely think that's not going to work. So please be open-minded and realize that sometimes people have issues that need past abuse or other people's abuse of a medication does not mean that somebody else doesn't need it, and that in order to recover, they're going to be okay without it. Have some willingness to talk about it, and I'm not sure why I put recovery, but is the person recovering? Are you recovering? Are you working? Are you going along the path that is from being what you were to being who you want to be? Okay, so the doctor's note. I'm going to skip to this one real quick. So this is what the medication memo looks like. It discusses narcotics. I don't think the technical term for stimulants is, I don't think a stimulant is a narcotic, but maybe the doctor can talk a little bit more about this. We just use it this is a general guideline. I'm not going to read it, but here are the basic things you need to do. It needs to say the name of the medication. In the note, it says the doctor needs to say that there's no suitable alternative. I just give the memo to my doctor and I say, look, I am in a recovery home. I need a note that lets them know that I am in recovery and you know this. And what the doctor decides to do is what the doctor decides to do. My doctors have not written notes that say exactly what the note says. I just give them to the house and I'm honest with them about it. It needs to say that the doctor knows that you're an addict. And if it's a medication that requires a length of treatment, it needs to say that. Okay, conducting pill counts. Verify the prescription information. The pills in there might not be the pills that are supposed to be in there. Look at the drug, look at the dosage, look at how often it needs to be taken. Don't be afraid to look at these labels, look at the bottles, but like everybody else said, we don't touch them. I touch my own medication, nobody else touches it for me. We are not house managers, we are not doctors. This is a medication label, I'm sure you've all seen them, but yeah, look at all this stuff. I'm running out of time and.
You are, baby.
All right, so these are some examples of lock boxes. I like the locked toolbox myself, but what the houses that I've lived in, we keep lock boxes and either a key or a reprogrammable code right by the newcomer paperwork. If somebody comes in, there's no, I can't afford a lockbox, or I don't know where to get one, or whatever. Here, you can borrow one. Lockboxes deter other members from, if somebody's gonna steal medication, we really need to ask, is it the person who is taking the medication that doesn't need to be here, or is it the person who's gonna steal somebody else's medication that doesn't need to be here? But still, it should not be easily accessible. It keeps children safer. A kid finding one strip of Suboxone, that's not good. That is not good. There's no missing meds. When you go to do a pill count, the person can't say, oh, well, they're supposed to be 26, but I don't know what happened to the other 23. Well, it's been locked up, so you tell us. Okay. The biggest issue I've seen with other people in houses, the lockbox must stay locked. Okay, I've seen people expelled for being irresponsible with their medication. I took out trash one time and looked in the house window, and there was a bottle of the person's medication just laying on their bed that you could see through the window. That person was expelled. So we have to be responsible with them. Focus on behaviors, whether it's a mental illness, whether it's a medication, whatever it is. Behaviors are what is important. Whether it's about you or a housemate, what are they doing? What are you doing? Is your daily routine on? Is the person engaged in recovery? Are they getting better? Are their relationships improving? Are they moving forward in life? Is whatever's going on with them going forward? Are they growing? And are they adhering to the house guidelines? That's a real easy way to see if somebody is doing what they need to do. We have some boxes that we check. Are you going to meetings? Are you talking to a sponsor? And that's all. I really thought I would be less nervous up here, and I apologize. But I hope that this was helpful in some way for you guys. And thank you for letting me be here.
You did wonderfully.
I need to have my water.
And last but certainly not least, we have Dr. Kenneth Hoffman. He's a MPH, retired colonel of the Medical Corps in the U.S. Army. He currently serves on the Oxford House Board of Directors. He is currently the Collaborative Care Consultant for Absolute Care, Medical Director at the Stephen Coyne Military Family Clinic at Easter Seals, Medical Director for Maryland and Virginia MAP, Health Management and Peer Recovery Specialist, and maintains a the man is booked and busy. And maintains a consulting practice with Diversified Counseling Services. Dr. Hoffman was in Tanzania as a consultant helping establish an addiction treatment center. Dr. Hoffman retired from the U.S. Army in 2004, where he had been the Army Surgeon General's alcohol and drug consultant. During his service, he was the principal investigator for a congressionally directed study on the feasibility for recovery homes to help TRICARE beneficiaries. From this study, he learned about Oxford House. Following retirement, Dr. Hoffman was a senior medical officer at SAMHSA in the Division of Pharmacologic Therapies, and later the clinical director for mental health at the Department of State until 2017. A graduate of Cornell University, Dr. Hoffman received his MD degree from Eastern Virginia Medical School and his MPH from Harvard University School of Public Health. He's booked, busy, and blessed, okay? All right. Just a skosh more. He completed psychiatric and public health residencies at Tripler and Madigan Army Medical Centers. As a faculty member at the Uniformed Services University, Dr. Hoffman directed a Center for Training and Education in Addiction Medicine and optimized health model for recovery from addiction. I welcome Dr. Hoffman.
You probably took more time than I'm going to be talking. No, but that's awfully kind. And actually, what's been beautiful about Oxford House is it really brings together a lot of what would be good medicine. It would be having anyone here as a patient, because we would be working collaboratively together on your recovery, and that recovery process actually I could say holds for any illness. Mental, HIV, whatever, everything has been talked about. To have the support of peers that, care about you is critical, and, and it's mutual. So, I couldn't think of a better model. So the first question I've done over the last few years has been, how many people in this room have actually had a provider, or maybe a current provider, who you thought knew something about addiction? Raise your hands. So maybe it's 30, 25% or something like that. So here we're talking about kind of talk to your provider about, that you're an addict and that somehow they're going to be doing the right things. Tell you the truth, there's very little training that goes on in the field. If you are a specialist in addiction medicine, it's because you as a person have taken additional interest. That's what happened to me. I came across a mentor early in my training who was a walking encyclopedia, had developed the military program, but in all respect. And then the other thing was that the way the programs were working was with the expectation of recovery, basically full remission, back to work. And it was successful about 80% of the time as the data was published about 1990. They don't do that anymore because that wasn't civilian standard. So the standard now holds, I think, mostly if I needed treatment for an addiction, I would get the same type of treatment that we used to give all the active duty people in the 70s or 80s and 90s. Okay, spilt milk. But that said, the beauty of Tanzania was actually, it was that kind of care that I wish we had here. So what I see here right now is probably about the most fragmented healthcare system anyone could possibly design. How you negotiate it, I have my hats off to you, because with the people who've had providers who knew something about addiction, have you shared that with anybody else in your house, or is it, if it was relevant to do so? Because I think that's what, the bottom line, I think that, we really need to have a network, who's connecting to people in Oxford House who actually know something about addiction and know what you're talking about in terms of, I'm the doctor, of course you're supposed to take these pills. But the reality is that, number one, what is medication anyway? When I see a patient now, and especially in the Easter Seals, in that military family clinic, everybody has a therapist. And my job is to support the patient with their therapist. And what are they doing? They have very defined goals. They're also engaged in an evidence-based, dynamic therapy that, anxiety, depression, every mental illness, or whether it's an illness or not, there's basically an endpoint for therapy in terms of getting goals. If you went to physical training, I want to learn to play golf or something like that. You'd have to learn how to swing the club, and it's kind of a strange way, it's not totally natural, but you have to be trained. You have a coach. And if you just go to the coach once a week, to kind of practice your swing, you're not going to go very far. But if you practice every day, practice makes permanent. Doesn't make perfect, makes permanent. But it's going to take time to be comfortable with it. So I can do anything for a month. I might not like it, but I can do it. because it's good for me. That's taking action. But when is it my habit? It's going to take, and the brain will be changing through that period too. It's going to take 3-6 months. And if you look at the outcomes of Oxford House, they're really best if people have been with it for 6 months. You have most of the problems early on, not later on. So the other thing I think the take home would be don't be defined by the medication. It's a catalyst. It helps you get to where you want to be. That's how I see it. The other thing I've noticed, which is this is where the interaction is important. And again, learning from Tanzania, which actually had a really great process flow diagram. It's the 25th poorest country in the world, but there's very little wealth disparity. Most people are poor. So what they do has to be very targeted. And what our government was providing is that you have to, for the opiate clinic, you had to take methadone was the only option at that clinic. Plus the HIV was part of PEPFAR, so they were giving PrEP, the pre-exposure prophylaxis. So with that, okay, my goal was nobody should die from methadone. Methadone is a drug that, they try to ramp up from 15, 30 milligrams up to over 60 milligrams and sometimes much higher. So when you look at that little whatever take-home dose is, you don't know whether it's the low one or the high one. But if it's a high one, you can die, literally, with that dose that you've taken. If it's, unless you're tolerant to it, in which case it's what you need, to feel whatever, normal. So that said, that with the Tanzanians, it was interesting to just to see how the interaction was. My goal was to kind of ramp up the number of patients seen. But they had such a good process and such a good interaction with the patient. We really were able to do an awful lot. And what also happened is that people came into the clinic with a kind of a community support person, some helping other person. And that person will also take, if you couldn't get hold of the patient, you could get hold of that other person. So very early on, it was like the social support. Now, in my mind, Oxford houses or that model would have worked very well there because a lot of people are homeless, or a lot of people, how they go from day to day. Okay, so back to the United States. So as I say, don't be fooled. Now, the other thing is that with most medications, there's always an option. So what makes a controlled drug a controlled drug? It's all defined by basically DEA, FDA. It's a drug that has significant abuse potential. So the only ones that are considered the high, the Schedule ones are, no medical use whatsoever. That would be where heroin is, or some of the other things. And actually, marijuana is there also still for the federal, no matter what the states are doing, but it's still in that category. And that goes back to the way our the politics go, but also the effects of those drugs. Now, if you go to what are the two drugs in the Schedule II categories? There's only two of them. There's the opiates and the stimulants. Full stop. Now, talk about a condition. Okay, how did the stimulants start? Well, how does it amphetamine? In 1930 there was an antidepressant that came onto the market, and it was very effective. It was amphetamine. So that is the first antidepressant. You move to a couple of decades. What's happening in the 40s is that people are taking, because it makes me feel alert, I can work and whatever. In the 50s, it kind of becomes used a lot as a diet pill, and people really do lose a lot of weight, and for most cases. And then in the 60s, you get into these other antidepressants. So what differentiates a controlled drug from a non-controlled? The controlled drug tends to have a real fast effect, right? It's people talk about the brain and dopamine release, but you really feel good. I mean, why would a drug be abused if you didn't feel good, for whatever reason? So the other thing they all do is that they poop out. They go up, they come down, and they wash out. So the next dose, I feel good, and washes out. The problem is that over time, it's not having that same effect anymore. And that's where the body's kind of building a steady, it's not washing all the way out. There's a steady state kind of kicking in, more to get the same effect. The only problem is that the less, whatever these higher doses are, nothing is usually as good as that first dose. And people kind of get into this kind of merry-go-round trying to get to that. It's never going to be as good. Now, methamphetamine, by the way, is just a methylated amine. If I call it Disoxin, it's an ADD drug. Oh, and that's what happens in the 1990s, is that all of a sudden the amphetamines are back in as a, it was in the 70s too, but we didn't want to keep people on amphetamines long term. But for ADHD. But they become like primarily for ADHD, and so here we are today, probably consuming about 80% of the world's production of both stimulants and of opiates. Welcome to how we do medicine, and also it gets so the other flip side of that. If I'm having tolerance, I'm not getting the effect. The other side of it is I have withdrawal effect. So withdrawal, it's a flip opposite. So if I was feeling great, I don't have it, I feel really, really crappy. And those withdrawals, so the drug becomes kind of in a vicious cycle. How do I get out of it? And who do I talk to get out of it? So it's really, where do I go? So this is where treatment can fit in if someone knows how to work with it. Now, also in the 60s, there's another group of medications, and this is what usually is the preferred crowd, is the ones that you really do want to reach steady state. So, you get the first antidepressants. We talked about the SSRIs today, the Prozac group. It takes a while to feel better. You should go in the right direction, but now to get to the right dose. So it's so it takes a little longer, but you really do want the steady state. And then you have like 24/7 coverage. Now you get into the problems with, now that you have the, I feel kind of normal. It's not going to take away the stresses. It's not going to take how I manage the stresses. And that's where, what do I do differently? And that's where kind of a recovery model fits in. That's where therapists can be helpful, but also not all of it's alike. So, I take the antidepressant like Prozac, Alexa, Lexapro, Paxil, there's a bunch of fluvoxamine, fluvoxamine. One will be like, you always get that big warning, may cause suicidal thinking, significant depression, weight gain. You have all these negative things. That might be true for one. It's like, whoops, okay, wrong choice. Let's pick something else. The other one might, I feel like a zombie. I don't have any emotions. Something happened. Okay, that's maybe not a good fit either. And the third might be, it's like the Three Bears, I guess. But it's why wasn't I on this before? I really feel this is just fit. And then with that, if it's a catalyst, what do I do now? And get engaged with what people have been doing here with Oxford House, being part of the house, being part of the outreach, getting involved. And that social interaction is really where the benefits are. So, and I say, as we talked about HIV and hepatitis and, some of those drugs. Now, the problem with that, it's the same as with COVID now, by the way, is that we really have a problem with identification. It takes, I think, still 2 to 5 years to identify someone with hepatitis. When someone's first infected with HIV to the time they're actually diagnosed is still 2 to 5 years. At least that was in 2013-14. That was a CDC finding. Well, if I get somebody into treatment successfully, viral load is nothing, that person is not infectious. If the person is going to be going out with people who might be HIV, with a viral load, the pre-exposure prophylaxis is effective. The person will not become infected. If I was exposed to somebody, unknowingly or whatever, the condom broke or something, there's post-exposure prophylaxis, but it has to be started within 72 hours or, as soon as possible, but no later than 72 hours. So when we have this we have the stigma, we don't kind of talk, that's a problem. And once treated, by the way, as I say, it's about 51% or so, I think, of the population that was in that study. There's no infection. There's no spread. We're now going through COVID, same problem, right? You're most infectious when you don't know you're sick yet. And early on, when you are sick, you still are. But when you have all the antibodies, the infection risk has gone way down. So that's the so that's kind of our country. So So I think we should open it up for questions and any other, and you can go through a whole list of, but okay. Thank you. I have to see what I did with my hat.
All right, so we'll have a few minutes for questions. Yes, sir?
Cool. Hey guys, my name is Greg and I'm an addict. I'm from the Fellowship House in Falls Church, Virginia. So,
Hey, guys. Excuse me.
how do you avoid contempt prior to investigation for people who are on an exceptionally high dose of MAT drugs when they apply to your house and they don't do an in-person interview? So I can't really gauge their behaviors. They sound good on the phone and they are on what I would say is a very high dose of Suboxone or Adderall for what I would think is they're not sober.
Sarah, would you like to? Okay.
So I would go back to focusing on behaviors. He just brought up that slide. If somebody sounds good on the phone, if they answer your questions, if they talk about being active in a recovery program, I would say give them a chance. I was on a very low dose of methadone when I was out, just so I could, not have to be sick before I went to probation. Some people, and I was almost never awake. And then I was on an exceptionally high dose of Suboxone, and I was very normal. So people react differently to different medications, and whether they're on drugs or not, it's how they're acting. It's whether they're a productive member of the group and a supportive member of the group that's going to matter.
Okay. And
Wait. Yeah, a little bit.
okay.
Sorry. Thank you. If you would like, she's available after the group.
Absolutely.
My name is Felicia and I'm an addict.
Hey, Felicia.
I have a question. So if, as you're taking as prescribed, would you still become addicted to them?
Dr. Hoffman.
Yeah. I think now you're getting to the point that it's good to have the network of providers that understand what addiction is. As I say, so I think, if you're on a controlled medication, there usually are alternatives. So with ADHD, one could look at Wellbutrin effects or some of the actually blood pressure medications. By the way, always have a list of your medications and use the same pharmacy if at all possible, because the medications really can interact. So anything that hits like norepinephrine systems can help. So just to say that, yes, you can still become addicted, but if you recognize what's happening, that the doses, you're not getting the same effect, that you feel the compulsion to take the drug, really need to discuss that with the provider who's prescribing, or go for a second opinion. And someone who's like in the American Society of Addiction Medicine or who has an addiction qualifier is a good person to seek out.
All right,
Thank
thank
you.
you.
Dr. Hoffman.
Hi, I'm Jessica, and the question that I have is, so based off past experiences that we've gone through a house, we talked about like the RX date. Now, what if you go and you do that pill count and it's off because they picked up the script a couple of days past the time they filled the script? Do you see what I'm saying?
So I think I would like to take that one. So, so Jackson had a really good presentation about the differences between misuse and abuse, right? And so the difference is intent. And so we want to make sure that we're assisting individuals get on a regular scheduled program with taking their medications as prescribed, because when I was out there, baby, I didn't know when I was picking up my scripts. I didn't know how many I had left. I didn't know when I was taking my pills. I would just pop them in at whatever time of the day and then just go about my business because I wasn't really concerned about it. It wasn't my primary focus. It wasn't my priority. And so when we inform individuals that live in the house that this needs to now become something that you need to focus on, I think it's our responsibility to assist them with being held accountable and showing them what accountability looks like. And if they cannot get on with the program, then that may be some abuse that's happening that may potentially get them expelled.
Okay. And just for a quick
And behaviors.
And a quick general education. The dates are really confusing, I'll tell you, as a provider, because you have the date prescribed, which is on the prescription. You have the date filled, which will be done by the pharmacy. If the person already has, that it's not, they can overlap. And there's nothing necessarily that the pharmacy will do to overwrite a refill that was already there before you get. So there's a lot of confusion in that. So the real issue is what's on the label. Is there a doctor? Is it being taken as on the label? The problem some people will have, I think, in Oxford House is the ones that are given as needed.
Yeah.
And the as needed, genuinely, I mean, those are medications, again, that you don't necessarily want to hit steady state, but like they might be rescue. And what I'll be looking at is, okay, if someone, let's say, has lorazepam or something for the panic, they've had 15 pills in the bottle that's lasted a year. Perfect. They have it for security. It's not okay. I usually don't prescribe that. I can think of a few others, but it would be the same issue. Take it when needed. It could be Atarax or hydroxyzine also has some anti-anxiety type. So be aware of, and that can be, if you have a good relationship, if the person is given consent to talk to the doctor or somebody. I mean, I'm always receptive to somebody who's with the patient.
Thank you, Dr. Hoffman. And we have time for one more question.
Thank you.
My name's Jeff. I'm a recovering alcoholic. How would the House address the random and regular drug testing with someone on a controlled medication?
I'm sorry, say it again one more time.
How do we address random drug tests in a house if you have someone on controlled medication?
So I would like to say that Oxford House does not have drug testing in its model, right? And so Oxford House is based on behavior. And so we really need to be identifying what those behaviors look like so that we can hold the person accountable for change in behavior. Even if they're on an MAT medication, we're not addressing the medication or the prescription or the dose. We're addressing the behavior and how that's affecting the house. Does anyone else have any?
I would just like to share one of the things that I did when I was on a controlled medication in the house is I signed what Dr. Hoffman just referenced, a release of information. I was drug tested every time I went to my physician's office, and I gave my house access to that information. So if they were curious, they could just call and find out. So as Jeremy said, drug testing is not in our model. We do focus on behaviors. However, it's not prohibited by our model.
Right.
So it really is, it's up to the group whether that's something they want to do. I just don't ever want to see it being misused.
Okay.
And thank you guys for attending our presentation. I want to thank our presenters, Ms. Elizabeth Lewis, Jordan Link, Sarah Graham, and Dr. Kenneth Hoffman.